Marita from the Nurse Lounge, and today we are going to talk about something that someone asked me recently about how nursing has changed over the years. So I'm just coming to give my 2 cents. This is not something that is actually research based. Obviously, this is just a video on my opinion, in my opinion only, about how nursing has changed for me. So as a reference, I have been a nurse. I'm an OBGYN nurse, nursery nurse, well, baby nursery nurse. And I have been a nurse for 15 years. I graduated in 2004 with my BSN. And I went straight into OB right out of school. So I was lucky back then, because back then they really pushed for you to go to med surg first and then get your year experience in med surg and then transfer to any specialty that you thought you were interested in. And I did not want to do that, and I have no regrets about doing that. But that's not what this video is about. This video is really about how things have changed, in my opinion, in the past 15 years as a registered nurse. And basically why I'm really trying to get out of bedside nursing. I find that when it comes to bedside nursing, you either love it, can tolerate it, or you hate it. And I wouldn't say I hate it per se, but I am no longer interested in being a bedside nurse. I'm transitioning out as we speak, as I finish my doctoral degree in 4 months. So I'm transitioning out of bedside nursing. I am a PRN. I do work PRN in the hospital still, just to keep my skills, the few skills I have, abreast. But outside of that, again, I'm trying to transition out. So let's start with in 2004, or even in nursing school, 2002 to 2004, I came in during a time in which we were going through the change from from paper charting to computer charting. So I learned how to chart both ways, on paper as well as on computer, while in nursing school. And I found that to be very beneficial, because when we have downtime, I know how to make a narrative note. I know how to do a SOAP note. I know how to chart, alert and oriented. I know how to chart those things for the different systems that we're talking about. And then I know how to actually, write up to kind of finalize a note, and how to document accordingly and so forth. So we were transitioning from that back then. I will say this, in terms of what other changes have occurred, hospital nursing or bedside nursing has become more customer service oriented. So what I mean by that was, I felt like back in 2004, or my early nursing days, we had more backing from management. We had more support from upper management, from the executive level, from CNOs. And we have changed the model from what nurse knows or nurses best to the patient knows best in customer service. And if you understand customer service when it comes to either retail, fast food, or any other type of entity that customer service is of paramount importance for, the same thing holds true in nursing. And we are made to feel like, or in my opinion, we are made to feel like that our knowledge base is secondary to what a patient may say, because they have read it on Google or whatever it happens to be. And we are no longer considered to be, even though we're the most trusted profession 18 years in a row, nurses are, somehow we're always questioned about our credentials and what we actually know by patients and things like that. Or we have kind of moved into a mindset of where, we have to break policies for them in terms of visitation, in terms of diets, in terms of different things like that. And I'm not really for that. I'm not going to really do things like that. I am one of those who, this is the policy that's set forth by the hospital or by the unit or whatever, if that's what I'm going to follow. I have nothing wrong with nurses who tend to break policy as a favor, as a courtesy, or whatever. But when they don't explain that this is a courtesy and this is not what was required, that creates a hardship for the next nurses to follow. So customer service oriented has changed. Charting has changed. So we are now, most places are now doing computerized charting, electronic charting, EMR, things like that, scan systems. We were not doing that back then. Back then we had a drawer that had your room numbers listed, and that was such and such as room 4201, 4203, 4205. That may be your 3 rooms, and you had to put in your code in this little box, and then those drawer, or whatever drawer you needed, would open up based off of that. That was how secure it was. We didn't have a Pyxis when I first started. Or actually, we did have a Pyxis. They were again transitioning from Pyxises to, or from med cabinets, med what do they call those things? Med cabinets, I don't know if they were med drawers, maybe. I don't remember what they were called, but anybody's been a nurse longer than me, 15 years, or working a LTC knows what I'm talking about, where you have a cart, med cart. That's what it is. Med cart, where you have to put your number in or whatever your code in, or the code in, and it unlocks the drawers for you. So I've learned how to do that, as well as I've learned obviously how to use a Pyxis or AccuDose or whatever you call your system at your facility. So that is also a change that has occurred in terms of the levels of how these AccuDose or Pyxis systems work has changed over the years as well. So that's one entity. When I came into nursing back in 2004, you had to have a BSN in order to be in management, period. Now you have your 2-year ADN nurses who are in upper management. Now, is that because of who they know? I have no idea. Probably so, of who they know. But again, not to go there, but the ADN is not meant to be in management. The BSN is. That's why there's a difference between the 2-year and the 4-year degree. That is factual. So that is something that you can go look up. That part of it, what I just said, is factual. That was the intent of the 4-year degree, because the 4-year degree can go into upper management because they have had leadership courses in their program. The ADN does not have those same courses in their program, hence as to why they are typically not supposed to be in a management position. However, sometimes it's who you know, not what you know, and that's why these people are in those positions, or they're the best qualified for the situation. I don't know. But it's just something for you to think about in that regard. So that's changed, where you don't have to have certain kind of degrees in order to be in the management position. But that's how it was back then, and you had to have so many years experience and even try to move up into that. I've already mentioned you had to have so many years experience in an area. That's changing now before you go into another specialty. The change is now they have new residency programs or new graduate programs where they will have nurses come out and just train for a year in L&D or OB or nursery or a residency program. Or they have residency programs, which is new to me, where you go for a year or 6 months or how much time, and you go work in different areas as a nurse, and then you kind of get fine tuned and pick where you want to be. We didn't have any of that. You just went to where you went to. So if you wanted to be a ICU nurse and they were hiring new grads for ICU, that's where you went. You got trained and oriented, and that's what the job you had. So that's not how it is now, or at least that it is how it is at some places, but not all. You know, they have these different programs for that. There are some schools that actually have what's called a transition to care program. Transition to practice, not care. Transition to practice program. I actually did research on this. And basically what it is a hospital and a school of nursing has a contract together where that school of nursing does clinicals at that site, at that clinical site. And they do their preceptor there. And while they're doing their preceptorship, the nurses are training them to do the job that they would normally have when they actually finish school. Then the agreement is once they finish school, they will automatically have a job in the med-surg unit or whatever unit it happens to be at that facility. That's called a transition to practice program. So look that up and see if they have something like that where you live, because that would be a great opportunity for you instead of trying to have a hard time trying to find nursing jobs. If you go work there for a year, you will always have a job there, and then you can always move on after the fact if you're not interested in staying there any longer. All right, so now let's talk about the patient aspect. How has nursing changed for me in the past 15 years regarding nursing, the patient side? Well, as an OB nurse, I would have to say that the patients are getting sicker and sicker and sicker. When I first started to be a nurse in OB, it used to be that having a C-section was a complication of pregnancy. It just was, because people were just having, natural vaginal births. Now they are scheduled as such. They're scheduled. Having a C-section is not a big deal anymore. You have C-sections. That's just what they do. In addition to that, my patient, I've told you all before that I live in Tennessee. We rank number 3 in terms of the opioid crisis, and our patients are getting very, very sick because of the fact that they are using these drugs. They are using meth. They are using heroin, crack cocaine. It used to be, if someone's like on marijuana, like, oh my gosh, you're on marijuana. Now I'm like, okay, that's all they're on. They good to go. Because now it's like, which drug of choice do they have? Is it, I've had 2 patients in the past, I want to say month or 2 months, that was withdrawing from some type of drug. My last one, just probably about 2 weeks ago, was withdrawing from methadone. Actually, she wasn't even my patient. She was another nurse's patient who I happened to go in there and assist with. And I began to realize, I said, she's withdrawing. I could tell by the signs and symptoms that she was actually withdrawing from something. I didn't know what it was at the point in time because, again, it wasn't my patient. But eventually I could figure out that she's meth. I could just tell. So, we are dealing with more complicated patients in today's time. We are dealing with patients who are not just coming in having babies and going home. They're coming in with high blood pressure, with diabetes, with on drugs. They're coming in undernourished or overnourished in terms of obesity or malnutrition. They're homeless. They're mentally ill. I had a schizophrenic, psychotic patient who had a baby who said the devil was coming out of her, and she was psychotic. And so, again, we're dealing with these complicated situations. High-risk OB has become my new specialty, so to speak. Not in the sense that that's what I want it to be. That's just the reality of how it is. I am a OB nurse, but what I'm having to learn how to do has to pull in those med-surg aspects in terms of, okay, what's going on. I had a patient who I think she was in septic shock at one point in time. I've caught rapid response and had to, I never had to use rapid response. I probably used rapid response more in the past month than I have, 2 months, shall I say, than I have in my entire 15 years of being a nurse. That is saying something about our patient population and how things are changing. These are some sick individuals that we're caring for. Postpartum hemorrhage, that is not a thing of the past. It's something that's very relevant for today. However, I can handle postpartum hemorrhage with my eyes closed. That is a complication of pregnancy. However, the one thing that strikes me the most is our drug, moms who abuse drugs. And then they have these other comorbidities such as high blood pressure, diabetes, things like that, or even mental health issues where we're not really addressing the mental health aspect with our patients at all. We do postpartum depression screenings on our patients, but then what really happens after that? Does that make sense? I mean, think about it. We try to get them in and out of the hospital because of insurance reasons, but our patients are mentally ill. So where are they going to go? And our doctors don't really are the best about tending to those needs. And so I'm really big on, are you able to take care of your baby after the fact? How are they mentally? Are they mentally stable? We have more DCS cases than you ever want to know. We are calling DCS all the time because a mom is, either don't feel safe at home or she has a history of drug abuse. Again, back to the drugs. So we're calling DCS, and that's another thing. They are putting more responsibility on us as the nurse than they ever have before. It used to be, I could go see my patient, come document, pass some meds, do a few interventions, and then maintain them throughout the rest of the shift. Now we are having to not only be, I always tell people, I feel like I'm the chaplain sometimes. You got to be dietary sometimes. We had to pass trays, a few weeks ago because they had fired, or either they had quit or fired all the what we call food ambassadors to bring trays up. So they wanted us to go collect trays and bring them back to the patient's rooms and take the old tray out. And, we got to make sure the birth certificates are done for the baby. We have to make sure the hearing screens are done before we can discharge moms. We have to make sure that, just all their needs are being taken, just make sure that those needs are being met. And that's very hard to do when you are the nurse caring for 6 patients. Another thing is acuity. Just as I mentioned with the drug moms, our acuity is much higher, but yet we have 6 patients apiece on our floor. So I have 6 moms with varying degrees of recovery in terms of how far they are post-delivery. And you could have 6 vaginal deliveries and it be a horrible day, or you could have 6 C-sections and it be okay day, depending on where they are postpartum wise. If they're postpartum day 1, there's times where I've had 3 fresh C-sections. The mom who had a postpartum hemorrhage, so that's 4 patients. Someone who's mentally ill, 5 patients, and the 6th would be someone who's just rude. Okay, so which makes it difficult to begin with. So that makes for a very difficult shift when you have a patient load just like that. So, those are something to think about. What is the acuity like on your floor? We used to have a system, like a number system. Like if you were below 24 hours or if you had IVs in, you scored a certain number. And based on that certain number, determine how many nurses you needed to care for that patient population that day. We don't do that anymore. What we do now is, okay, there's 18 patients and use the 1-to-6 ratio, so you need 3 nurses. It doesn't make a difference what the acuity is. That is very, very difficult. It's an easy cut and dry way to do staffing, but it's very difficult because of those 18 patients, let's say 12 of them could be fresh C-sections from today. And so therefore, if you have 6 or 12 fresh C-sections from today, you have 3 nurses. You're going to have to divide those to be what? So 12, 3, 4 nurses, 4 patients apiece. So you're getting 4 fresh C-sections at one time, plus 2 older ones, 2 other patients. If they may be fresh too, you never know. That's very difficult. And then you have all this documentation you have to do. I can go see a patient and assess my patient in say 15, 20 minutes, depending on what I have to do. It's going to take me 25 to 30 minutes to document all that because I have 9 to 10 different screens I have to document on. And then don't let it be an admission. Admissions always take forever to do. So, that's something to be mindful of. It's just the dynamics of nursing has changed. The expectations for nurses have changed, but yet our wages have not changed. We're getting paid the same amount of money to do more and more work. And every time you all go to work, if you're anything like the facility I work at, it's a new policy that I'm rolled out to say you got to do this one more thing that you was not doing last week. And it takes more time. And, we do our own staffing in our facility. So we, in terms of, not for staffing, but like, for instance, the charge nurse is in charge of staffing for the next shift. So we have an overall finalized schedule about what the staffing is going to be. But with one of those nurses called in for, say, night shift, she has to go around scrambling, trying to figure out how she's going to get another nurse. And she's only getting paid an additional 75 cents per hour to have this charge nurse role while she's taking patients herself. That's the reason I'm like, okay, y'all can have that role. I don't want the 75 cents for that. I just assume to take my 6 patients, do what I need to do. When it's time to go home, I go home. We are also being charged with a situation where we have to be clocked out by a certain point in time. Well, I understand the reason for that. And the reason for that is because of the fact that you don't want people milking the clock for no reason. Plus, think about it. When it's change of shift, you're paying 2 different shifts of nurses. So your budget for that time period is very expensive. I get that as well. But when you want to implement bedside nursing and you have 24 patients on the floor, and there's different nurses being seen in, moving about, trying to talk to other nurses about these patients, it's going to take you longer than 20 minutes to get that stuff done. So there's times where my nurses come in at 6:45 for change of shift. But then since we have to go to 6 people's rooms to introduce, give bedside report, then of course they're in pain, so they're hurting. So we have to go back and get pain medication. Now, mind you, in my situation, I've already asked my patients at 6 o'clock. I said, this is about to be change of shift in the next 45 minutes. I'm going to go ahead. Do you want any medication, anything I can get for you at the moment? They'll say no. As soon as you get in the room, when it's time to do change of shift, then it's called our bedside report. They're like, oh, I think I will take that medication. Well, guess what? You have to stop what you're doing. Or we'll finish the report, but then stop what you're doing after that. Go give the medication, update the nurse about that, document that you give the medication, and then the next nurse has to follow up within an hour. Well, if that's going on for 6 patients, that's going to delay everything. So then it's going to take me an hour or so to get out and I have to document everything that I just done as well. So again, I'm not trying to be a Debbie Downer. I'm sorry, everybody's name is Debbie, but I'm not trying to be a Debbie Downer. I'm just trying to say that this is the progress I've seen with nursing over the past 15 years, that we have went from a truly nurse-based, nurse intervention type model to a customer service. Healthcare is secondary, customer service is primary type model. And in the result of that, our patients are not getting any better. Our patients aren't getting better. They are frequent flyers that keep coming in for the exact same things. There is no real good discharge education. And no one knows how to take care of these patients because, again, nurses are coming in. We have new nurses coming in, but then they are not knowledgeable because they're not getting adequate orientation. Orientation is another thing that has changed. If you don't speak about having good orientation, you will get lost in the shuffle. Most facilities should be giving you, as a new nurse, about a good 4 to 6 months orientation. These 2-month orientations as a brand new nurse is crazy to me. I had 4 months of orientation when I came out of school back in 2004. And with the ability to say, hey, this is not enough time. I need to go ahead and maybe have another month, another couple of weeks or whatever. I was able to transition pretty quick and learn pretty quick, so it wasn't an issue for me. But for some people, it really is. So be able to speak up and say, okay, I need more time in orientation or something along those lines. But that's changed. We are now having issues with people who are coming off of orientation and still clearly don't know what to do. Um, that's pretty much it. So I mean, as much as I enjoy being a nurse in general, the requirements that they are trying to require us to do as nurses on the bed at the bedside is not sufficient, and it's not safe. And you have to make a decision at some point in time. Is this good for my license? Is this good for me? Can I support my family like this? What should I do? And I will not jeopardize my license for any facility, because they're not going to back you anyway. So anyway, that's enough on this topic. I just want to come and talk to you a little bit about what I've noticed things have changed in nursing. So for some of you seasoned nurses, or even the nurses who have new experiences, what some things have you noticed have changed from when you first became a nurse? Comment those things below. Let's talk in the comment section. Just let me know what you all think. What types of things, have changed for you since you first became a nurse to your current situation now? I would love to hear about it. Until the next time, you all take care. Bye-bye.